So, welcome to the session. We're really excited to have you here. Hope everybody had a good lunch. This session is Rehabilitation Medicine and Myotonic Dystrophy. So, that's what you're looking for. You're in the right place. My name is Genevieve Wieglip. I'm the Communications Associate at MDF. Today's session runs about 45 minutes. It'll begin with a presentation followed by a Q&A. So, save your questions for the Q&A. As a reminder, the Q&A will be reserved for community member questions. This session will be recorded, and we'll send recordings out at a later date. During the Q&A, the presenter will come on you, and you'll be brought a microphone. Speak only once the microphone reaches you. That way everybody can hear you. This session is provided by Dr. Nassim Rad. Dr. Rad is a board-certified physician and assistant professor with the Department of Rehabilitation Medicine. She serves as the director of electrodiagnostic laboratory and co-director of the Muscular Dystrophy Association Care Center at UW Medical Center on Mont Lake. Yes. Please give a warm welcome to our presenter, Dr. Rad.
Thank you so much. All right. So I'm going to try to keep the presentation on the shorter side so that there's room for questions. And also, I think they want us to get back on track. Normally I say cut me in the middle of the presentation, but this time I'm going to say, since it's not very long, we can wait till the end. So my goal today is kind of talk to you about what rehab medicine is. I think a lot of times there is confusion over, okay, I have a neurologist and what am I seeing rehab med for? And then I make it super confusing because I'm actually a neuromuscular neurology trained rehab doctor. And so those of you that are patients of mine only see me. And so in this talk, I'm going to really focus on the role of the rehab medicine provider and team. So I get the privilege of talking and sharing about our physical therapists, occupational therapists, and speech language therapists. So rehab medicine doesn't really exist in isolation. We are, by nature, a team-based physician group. Whether or not we're taking care of patients on the inpatient floor or seeing you in clinic, our approach is always wrapped around other physicians, and at the center of the team is you and your loved ones. And our goal is to help identify areas of impairments and then come up with individualized treatment plans. So, myotonic dystrophy, as you've heard from the first sessions, and as you're probably very familiar with from yourself or loved ones, is not a disease that just affects the skeletal muscle system. Much of what we're going to touch base upon today is going to, have an impact on the skeletal muscle system. So this is only one aspect of the rehab medicine approach. So when you have a visit in your rehab medicine clinic, it's really going to be a comprehensive assessment. You're going to have lots of questions and then a thorough exam. We're going to be looking and spending a lot of time dedicating ourselves to what is your functional status. What are the things that you can do? What are the things that you can't do? And as we see you over time, I like to ask patients, what are the things that you can no longer do or need more help doing since the last time I saw you? We talk a lot about mobility, whether or not you're, independent with mobility, whether or not you need assistive devices or are in manual or power wheelchair. We talk a lot about strength and range of motion and evaluate your strength and your range of motion, as well as your balance and coordination. And then if you're new to myotonic dystrophy or the neuromuscular world, you might not be as familiar with the term activities of daily living. For those of you who are not new, this word is probably very familiar to you. It is something that is a term that we use in our neuromuscular disease clinics, but insurance companies love to use it as well when they're trying to figure out if they're going to cover a product for you or device. And essentially, activities of daily living are everything you need to do to get through a day. So you need to be able to get up, get from point A to point B, get dressed, bathe, use the bathroom, eat. I largely argue that there are other things that are important in the day, but these are the absolute have to get through during the day. And we want to make sure that we are assessing that and the limitations for that. So again, our goal is to maximize function and safety. So I want to highlight this question in that it focuses on what is the most common cause of morbidity in myotonic dystrophy type 1? So morbidity is different than mortality. So you'll hear a lot, or if you were in the cardiac talk with Dr. Owens, you probably learned a lot about cardiomyopathies and arrhythmias, and unfortunately, how they can sometimes take our patients' lives. What I'm talking about is what influences your quality of life. And studies have shown that what patients with myotonic dystrophy have identified are gait instability, falls, and fractures. So these are the things that most commonly worsen morbidity in myotonic dystrophy. I also want to take a moment and highlight that falls can increase your mortality as well. Like, I'm only talking about morbidity, but it's important to know that falling can also have very serious consequences. So our counterparts in Germany, Netherlands, and UK have done a really phenomenal job on collecting data. I think somebody, and I don't know if they're in this group, had asked the question about what about qualitative studies? And so those do exist. And I'm pulling out one of those studies here that gathered 573 participants to answer a web-based survey. So that's a really high number of patients with myotonic dystrophy, and asked them about questions regarding their falls. So the average age of the person completing the questionnaire was 46 years old. We're comparing it to unaffected individuals over the age of 65 because that's the data that the control data on falls that we have available. And based on that, our median age 46-year-old with myotonic dystrophy was 2.3 times more likely to fall than an unaffected individual 65, so almost 20 years older than them. In this survey, 30% reported a fall in the past 6 months, and 77 had at least one fall in the past 5 years. The colors on the graph aren't super important because they just narrow down what country. But overall, the takeaway point of this slide is that the most common causes of falls were balance and weakness. They kind of lead the group in impairments. And so this kind of highlights the reason that we harp on seeing you in follow-ups and try to maintain your function, because our goal is to reduce this number for the patients that we see. So I'm going to take a minute to touch base on who are members of our team and who you may be referred to, and briefly what they do, and then we'll dive back into other topics. So physical therapists. Now, we're also going to talk about occupational therapists. Many times in the community, physical and occupational therapists may play very similar roles depending on where you live. But in a more formal sense, the physical therapists are going to be the individuals that are going to truly analyze your big gross motor skills, how you get from point A to point B. So they're going to be the ones that help address your mobility limitations. A lot of these individuals work in our wheelchair seating and positioning clinics to help us measure and work with vendors for mobility aids. In terms of exercise programs, I know for a fact that everybody would love to improve strength. And we do focus on the areas that we can improve strength with, but our goal is to maintain and slow down the process because we know that unfortunately this is a progressive disease. And so we want to meet you where you're at every stage. We want to improve your flexibility and improve your endurance, your ability to tolerate the same amount of activity that you were doing in the previous years. The things that we want to avoid are having you develop contractures, which mean if your muscle gets weak to the point of non-movement, if you don't have somebody helping or you're not able to stretch or range that motion, that joint can almost get fused. So, for example, you might notice it in individual hands. If somebody has weakness over time, the natural posture of the hand will be to curl up, and it can get to the point where I physically can't open up my patient's hands. That would be a contracture. Weakness would mean that if you came to the clinic, I'd still be able to passively move it for you. You can't control it. But if you get to the point where I can't physically open it or somebody else can't physically open it, then you have formed a contracture. And those are the things that we want to avoid. Our occupational therapists, again, in community centers, they may be fulfilling some of the role that our physical therapists are fulfilling. But in a more formal settings, these are the individuals that are going to be asking you in more detailed questions about your activities of daily living. So they're going to ask you, how do you get into the bathroom? And in detail, right? How do you transfer from the bed to whatever mobility aid if you need one, or how do you use your walker? How do you transfer? How much assistance does somebody need to give you? How do you get over a small lip in your bathroom, or do you use a shower chair? And what kind of shower chair, right? There are so many different options for that. Or is it a shower bench? Can you not remodel your home? And if you can't, then how can we find the equipment that fits best into your home? And then work-related activities. So everyone always thinks occupation means work. And so my patients will say, I'm not working. I don't need this. That isn't, you are working. You're working every single day to keep yourself strong and functional. But they can also help address if you are still working, they can help make modifications in your work environments as well. They do a lot of adaptive equipment for us. So again, they are not, trying to slow down your disease process. Fortunately, there's not much we can do for that, but their goal is to help you adapt your environment. And also talk to you a little about energy conserving technique. So we know that fatigue is a major part of myotonic dystrophy for several reasons, but one of them being just the pure nature of the disease itself, unfortunately. And sometimes the best thing we can do is understand our limitations. So we talk about you're going to have a certain bucket of energy for the beginning of the day, and how do you divide those tasks out? And they can help you with that as we can as well. Talk to you about what are the most important tasks, which are not always not all the tasks that you have to do, but in that most important is all the tasks you want to do, because again, we want you to have a good quality of life. And then understanding that the task list is never going to run out. So we have to have a little bit of acceptance that you're going to do other things the next day, and avoiding doing a lot on the day that you feel good, because that'll just mean a really bad day the next day. So the bucket kind of stays the same. We try to full it, but if you empty it, you're going to be starting from scratch. So occupational therapists are very skilled in kind of going over those specific tasks with you. Speech language therapists are another very important part of our team. I want to highlight here, a lot of times people have different notions of what does speech therapists do, right? Is it just my speech? And it's beyond that. So we think of, our mouth and think about all the different things that our mouth can do. So it can speak for us, it can swallow for us, and it can help us communicate our ideas. And so the speech therapist can help with swallowing evaluation. So this is a little schematic if you haven't had one or your loved ones haven't had one. If at any point it becomes necessary, you'll work with a radiologist and a speech language therapist who will have you eat various foods of different textures. So liquids, pureed, solids, coated in barium. And so right behind this schematic is an X-ray film. And so we can see a lifetime fluoroscopy image of where that food is going, which gives us guidance into, are there certain textures that you're more at risk of aspirating, meaning getting down into your lungs instead of your GI tract. The goal of that is not just to tell you, no, you can't eat these foods. That'll always be your decision, but it also helps them teach you different strategies, when to tuck your chin when you're eating to kind of guide those muscles into helping it get into the right tract. The speech therapists, yes, they can also work on the actual speech itself. So they can help with speech intelligibility, meaning how clear your speech is. And they can also work on devices if you get to the point where it's not clear or you're not able to communicate. We have a lot of different devices from teaching you, text to talk and different devices on your phone to if your hands become weaker to using eye gaze equipment. So using your eye movement to be able to communicate with devices. A lot of new technology has come out over the last few years. And so, and then as Dr. Wong has mentioned, in the general session, we know that our thinking and executive function can be affected with myotonic dystrophy. And so they also are going to be the ones that kind of help with memory, and toolkits to put together with how do you preserve those functions and make use of different equipment. So taking a step back, going back to maybe the realm more of physical therapy, but also your rehab physician, they'll talk to you about different devices and orthotics. And so some of this is pertinent to everybody, and some of it just depends on where your weakness is. So in myotonic dystrophy type 1, we have a lot of distal weakness, hands and feet before it starts creeping up. But in those of you with myotonic dystrophy type 2, you'll recall, okay, my hands and feet feel pretty strong. It's my shoulders and my hip joints and my more proximal muscles. So in some cases, an ankle foot orthotic, which is used to when you have foot drop, or wrist splints when you have wrist weakness, maybe the first type of equipment you get, or they may be the last type, depending on where your weakness starts. We like evaluating patients to get them started with the least invasive form of mobility equipment. So starting with canes, transitioning to walkers and wheelchairs. And again, as I mentioned, myotonic dystrophy goes beyond the skeletal muscle. So when we're looking at mobility equipment, we're also taking into account your cardiac function, your respiratory function, and how fatigued you are. So you don't always need to just have pure weakness to be using a mobility device. And then the adaptive list of equipment I'm going to jump to on this page, and I'm sorry, the writing's a little small, so I can also read out some of these. So some of you may have these, some of you may not have heard of these, but essentially these are going to be tools that'll help you with the tasks that you're doing on a daily basis. So things like reachers and grabbers, adding foam blocks or foam buildups onto your utensils to make them have a larger diameter so they're easier to hold onto, button hooks and zipper pulls if you have fine motor problems, dressing sticks so that you can help pull your pants up or reach across an area of your body you can't get to. And then in terms of home adaptation, so installing ramps, chair lifts, grab bars, and raised toilet seats are some of the most common home modifications. For those that are still continuing to drive, there's hand controls that individuals can use if their legs are affected to the point where they can't move to control gas and brake. And then even if they're not driving, but how do you get from point A to point B with a loved one driving you, would be wheelchair lifts in the actual car themselves. Voice control devices. So these aren't just the speech communication devices. These are things like using Alexa in your house to be able to set up light switches and kind of operate your home environment so you don't have to move across the room to flick a light switch. And then computer adaptation. So if you have problems with dexterity, we still want you to be able in this day and age to communicate via email, communicate with loved ones, surf the internet, read on your Kindle or your iPad. And so the list is pretty endless, but our goal is to kind of help you walk through everything that you want to do and need to do and make it easier for you. One of the things that I said I would touch upon in this lecture was also pain, because I don't think we can get through a conference without talking about pain. It is a huge barrier to patients' quality of lives, and it is commonly overlooked because by nature, muscle diseases aren't normally painful. But if that were true, then these facts wouldn't be true. So about 50 to 80% of patients with myotonic dystrophy type 2 confirm that they have pain, and 45 to 77% of myotonic dystrophy type 1 have pain. I also want to highlight that for many people with myotonic dystrophy type 2, they go through long periods of being undiagnosed. I know it's probably hard to get a diagnosis for everybody in this room, but for type 2s, sometimes their first presenting symptom is pain. And that can lead them through a lot of different specialists before they get their diagnoses. The studies have shown us that the longer you have your disease, and interestingly, the worse your cognitive function is as a result of the disease, is associated with increased levels of pain. So why do people with myotonic dystrophy have pain if the muscle fiber itself doesn't carry pain in it? And so broken it down here into some of the most common causes, or types, I should say. We'll go into causes, but what are some of the most common types of pain? So one of the most common types of pain is musculoskeletal pain. On this slide, I'll go over like the description of these pains, and then we'll talk about on the next slide why they occur. So musculoskeletal pain, the words that I'm kind of pulling from patients when I'm trying to have them describe pain, or I look for the terminology, it feels very deep. It feels very achy. They point to like the actual muscle or joints themselves. We know that myotonia also can cause its own related pain. And so myotonia, for which the dystrophy is named after, means delayed relaxation. And so a lot of times when we're testing patients, you might see that we're like having you grab onto our hand and then let go. And it's very hard to let go. Or if you close your eyelids, it's very hard to open it. That can be associated with muscle cramps, stiffness, and spasms, which are all painful. And then neuropathic pain, as the name implies nerve, patients will describe their pain as shooting, burning, numbness, or a hypersensitivity. So, sheets on, when you pull your sheets up in bed, those should feel nice and soft. And if you're hypersensitive, a thin sheet can be really painful on your skin. Or if we're examining you and you were touching your skin, that might induce like tingling over your skin. Joint pain in and of itself. So when you have muscle weakness, your joints are going to be carrying the brunt of the work. And so patients describe the discomfort as, limited mobility to move that joint. Sometimes we'll visually see that the joint is swollen or warm. And then visceral pain would be pain that people associate in their abdomen or pelvic floor with, constipation or bloating type pain, or if they are having trouble urinating and the pressure of their bladder. So this kind of pain is harder for people to describe, but usually we'll have an underlying pathology that we're hearing from them. So why do these types of pain occur? I think the number one reason is because with muscle weakness comes muscle imbalance. And so, again, for the joint type, your joints, as we age, we try to say strengthen your muscles so that your joints don't have to do the brunt of the work. When your muscles are weak, so if we take into consideration your shoulder joint, if this is your joint and the muscles are surrounding it, as the muscles become weaker, the joint is taking on more of the work, but these muscles are kind of falling away from that joint. So then imagine having to swing this arm with this muscle not attached solidly to the joint. That's a really painful movement. Over time, it'll limit your ability to completely move your arm up, but the pain associated with it is similar to tearing a rotator cuff muscle, which again then leads to overuse injury. So if a muscle is weak in that area and you're constantly using it, over time you can get traditional injuries that we see for other reasons, like rotator cuff injuries. And for that reason, you may be referred to our sports medicine colleagues. So there are other people that are a part of the team, even if it's not the initial reason for injury. As I mentioned, myotonia means delayed muscle relaxation. And so something that is contracting and unable to relax is what generates that pain. We can have a peripheral neuropathy associated with myotonic dystrophy. On top of that, we're at higher risk for developing endocrine problems like diabetes, and that in and of itself carries a risk for peripheral neuropathy. So peripheral neuropathy injuries are what are responsible for that sharp shooting, burning type pain. And then central desensitization. So this is a term that can be used for a lot of chronic pain. So we understand the mechanisms above for why pain is happening. Over time, the body starts realizing, wow, everything is causing me pain. So the way it processes pain gets altered. So things that weren't painful day to day and maybe don't have a direct correlation to like this area of muscle weakness become painful. So the whole body starts aching. And this is what we call central desensitization, and kind of moves us from, you can start with pain that's, very disease specific to transitioning over to chronic pain. Everything starts from your disease, but there's a little different way that we kind of manage the chronic pain. And then, of course, the things that we want to avoid are things like the joint contractures, pressure ulcers from not moving, and then the overuse injuries can cause tendinitis and inflammation in the bursa of the joints. So all of those are secondary mechanisms for pain, but they still result from the myotonic dystrophy itself. So when it comes to pain management, the way that the consensus of care for myotonic dystrophy has lumped it up is that we have pharmacological interventions, and we'll touch base on these, physical therapy, occupational therapy, assistive devices, and complement therapies that I won't be diving into because they're not my expertise, but things like acupuncture. And so for pharmacological interventions, one, your physician will kind of need to determine, okay, what is the cause of this pain, right? Is it an overuse injury? Is it the myotonia? Is it inflammation, or have you had it so long standing that now we're dealing with chronic pain? So conventional first line over the counter NSAIDs, which would be your ibuprofen and Tylenol, are always first line approaches for the aches and the pains that come one off with maybe overuse or a day of tremendous activity followed by a little bit of a rest. When we talk about the burning, sharp, and shooting pain, these are going to be the medications, and there's more than just the gabapentin and Lyrica. Those are just the most common first-line agents. Those are the ones that address the pain that originates from the nerve. Now, Once we start dealing with chronic pain, so pain that's everywhere, pretty widespread, we start looking at the literature for how is chronic pain addressed. And there's good literature to now show that using SSRIs, so even though these are mood medications, they are also chronic pain medications. So they're new generations of old generations of TCA like amitriptyline, nortriptyline. You just want to make sure that you communicate with your doctor because understandably with myotonic dystrophy comes like a lot of mood changes, understandably. And so if you're being treated for depression and anxiety, you want to let them know because there's going to need to be an adjustment. We can't give you two of the same medications. So it's really important to make sure you communicate those medications with your physicians. If it's just a one location type pain, using lidocaine patches or capsaicin can be helpful. And then if it's from the actual myotonia, muscle cramping, mixilotine is the unique medication that is used for treatment of myotonia related cramping. We also have some seizure medications as well, lamotrigine and carbamazepine that can be offered. They're older medications. For these medications like mixilotine, we'd want to, what's important is to understand your heart history. They're still very well tolerated, but there can be a cardiac risk associated with it in terms of what needs to be monitored on your EKG. For most patients, you should have an EKG because seeing cardiology is part of your health plan. And then muscle relaxers for muscle spasms that are not related to your myotonic movements. Yeah. Yeah, so it really depends on why. So they're on the bottom of the list because we don't have a lot of good qualifications for muscle relaxers. So this would be where you strained a muscle and you're going to take it for a short course of time. I wouldn't put somebody on a muscle relaxer long term. Yeah, so our muscle relaxer is actually kind of a misnomer. So it's not going to make your muscles weaker, but they're going to kind of, so if you use something like topical Bengay, some people kind of refer to that as relaxing the muscle, but we would think of your muscle relaxer as something that's acutely inflamed and we want to give to you. If you have chronic pain, we're going to move up into those other more neuropathic pain medications. But that's an absolutely good point. We wouldn't just have you take the muscle relaxer forever for chronic pain. And another notable thing on this list is we try to avoid opioids, right? So new literature shows us that they're not great for chronic pain. And they are not great for a respiratory drive either. And so there is a place for them. We are not anti-opioids, and there are other as-needed opioid-like medications. So some of you may be on tramadol that has like opioid properties, but isn't an opioid. So exercise. One of the interesting things about exercise and myotonic dystrophies is that for a while there was a notion with muscular dystrophies in general that the pendulum has swung. So before it was like, don't do any exercise if you have a muscular dystrophy. And then it was, no, you should be like exhausting yourself to the extreme. So with the traditional muscular dystrophy, so if we think about our counterparts with children with Duchenne's or Becker's or FSHD, where the protein problem is in the skeletal muscle itself. The worry was if you worked your muscle to the point of muscle breakdown, you would not be able to rebuild those muscles. Exercise is still important for them. We're not talking about that patient population, but that was the theory. So in myotonic dystrophy, people have questioned, should we be cautious with muscle fibers? Because the issue with, as Dr. Wong went into the detail of the mechanism, isn't inherent to the skeletal muscle, isn't a protein sitting in the skeletal muscle itself. And The truth is yes, we don't have very specific literature, but we have many secondary complications that would tell us that we need to have modifications in place. But on top of that, we still don't have literature that says that if you fully break down your muscle, would it rebuild as normally as if you didn't have myotonic dystrophy? So several papers have shown that exercise is safe with modifications. The benefit of it, is where there's controversy over how you use the term benefit. So if you're using the term benefit to mean you're going to get stronger, we don't have good literature for that. But if you interpret the term of benefit as pain management, improved endurance, improved range of motion, then absolutely. And so pulling apart two of the more recent studies in exercise and myotonic dystrophy, a 2019 review looked at 21 papers, and the papers all had different forms of exercises. So some of it was acute, some of it was using strength, some of it was saying aerobic, meaning just getting your heart rate up or balance, and there were no harmful consequences noted. Unfortunately, we don't have enough information to say this is the standard prescription. You should do this amount of aerobic, this amount of resistive training. In 2022 or 2020, they looked at exercise in a wide population of various muscular dystrophies, including myotonic dystrophy, including FSHD, and they pulled out 13 randomized control trials. So what that means is randomized control means that some people were given exercise and some people were not. So it wasn't just observational. They actually, had a protocol. Now, muscular exercise did not improve strength, which is not what we would expect it to do because it's not reversing the disease. But there was improvement in endurance with walking in the group that had myotonic dystrophy. So again, we're seeing that there is benefit. Most importantly, that it's not harmful. So there are different types of exercises that we talk about. So we can talk about exercises that are aerobic. Aerobic exercises are exercises that get your heart rate up. This is going to be like cycling, walking, swimming. They're good for your cardiovascular health. They're also good for endurance and to help you fight fatigue. And these we don't have concerns about these making your weakness worse or exacerbating your myotonia. So these are like I like to call them the low-hanging fruit, meaning like, yes, you should do them, and they aren't harmful. Then we come to resistive exercises. So these are the ones that are focused on strength training. And this is where we want to counsel you more on a supervised program. So for example, one of the things is if you can't move a muscle against gravity, and oftentimes to make it simple, say gravity is vertical. So if you can't move your muscle, up and down, but you can move it side to side, then you shouldn't be using weights. Because if you can't move something, if you're not strong enough to move it against the force of gravity, you're not strong enough to move it with weights, and that could actually lead to further muscle breakdowns and tears. And then one of the most important forms of exercise that gets overlooked is functional exercises. So they target specific muscle groups and patterns to help you become more independent. So you might hear us talk about sending you to physical therapy to work on your gait with equipment. We are doing exercise for a very specific task that we want you to accomplish. There are a lot of modifiable exercises. Movement is so key. And I think that patients forget, as I mentioned, when patients are like, oh, I don't have an occupation. You do. You're working every day and you're probably working harder than you think. Our goal is to keep you moving day to day, whatever it is that you enjoy doing. So, doing the laundry, going outside into your garden, walking up and down your stairs, walking your dog, changing out the dishwasher, that takes energy to do. And that can all count towards exercise depending on your level of strength. So, if you're fully able and unaffected, okay, maybe you're not using it to the max. But if you have limited ability and you're able to execute those tasks, you may be increasing your heart rate to just complete that task. So we want you up and moving as much as possible. And first and foremost, doing the things that you need to do and that you enjoy moving. And then lastly, I think one of my favorite parts about being in rehab medicine is our job as educators and support systems. So our job is to educate patients and their caregivers and their families. Whether it's to help you preventing you from falling, help you come up with adaptive strategies or community resources, or connecting you with your other counterparts. So we work very closely with neurologists, geneticists, pulmonologists, cardiologists. We're all just a big part of the team that's here to help you. And I think I didn't fulfill my goal of ending early. Question. Yes. Yeah.
So I love the fall prevention, but my husband said sometimes, especially maybe when I'm a senior, I am going to fall.
Yeah.
So he wants to find is there a way to fall safely or gracefully? That's what he's looking for.
Great question. I love that question. And yes, there is. It's a little different from everybody. But our physical therapist, and so I don't know where your husband is seen, but I will send to my physical therapy and write floor recovery. So you can also have him ask locally. So floor recovery is a term we use for how do we fall, and then how do we get up from falling. And so in many ways, we still have the strength or in our body to get up from a fall if we just knew how to do that. And so floor recovery is the terminology that you're probably looking for, but I think that's one of the most important things that physical therapy can teach you how to do, is how to recover. Absolutely. Yeah. Great question. So bone density, so myotonic dystrophy is the gene for myotonic dystrophy doesn't code for reduced bone absorption like some other neuromuscular diseases. So bone density is a matter of how long you've been ambulatory for and weight bearing for. And so once you have moved into a mobility aid, your bone density may go down. So if you started in a wheelchair at a younger age, you're going to be higher risk for lower bone density. And then genetics, right? Regardless of your disease. So if you come from a family that has, lower bone density, in terms of increasing bone density. So again, staying as ambulatory with safety, right? We don't want to just keep you ambulatory without being safe, because that's going to increase your fall risk. And then we usually refer to endocrinologists if you've had what we call fragility fractures. So major fractures to your bones with minimal activity. So not, okay, I fractured my bone because I was in a car accident. That could happen to any of us, right? But a gentle or assisted fall to the floor and you fracture your femur, then that's when it might be time to start medication beyond just calcium and vitamin D, which all patients should be on. But if you're not taking calcium through your diet, everybody should be on vitamin D. Yes.
When muscles are strengthened, they do on the micro level get here.
Great question. I'm just going to summarize it for those that couldn't hear. So we've been doing strength training and aerobic exercises with concern that would the strength training be leading to micro tears that would eventually be expediting the disease condition. And so we do counsel on something called delayed muscle relaxation, which delayed muscle breakdown. And so what we're looking at is when you're starting a strength regimen, one, you again have to be able to move those muscles against gravity. Two, any strength training that you do that leads to muscle soreness for more than 24 hours is what we assume is causing those micro tears. So we don't know for certain, but if you do something and you're like, wow, I'm still super sore from it, we're presuming that you're having micro tears. And then we would say you need to either change the rep or the intensity of it as a precaution. And so we're trying to find a sweet spot between not exacerbating the tears, but also getting some strength exercise. Oh, I think I'm.
Right. No. Thank you so much, Dr. Rath. Yes, big round of applause. Thank you so much.